Okay, so for this video, I'm going to kind of do a quick assessment that I would do for someone that I would suspect to have a chronic left ACL tear. So first I would do a quick palpation of the knee joint. So I'm just going to roll up the sleeve, really get a good idea of the joint. And then starting with the patella itself, pain here.
No.
And then just moving down to the inferior pole. And I mean, I really wouldn't suspect any kind of pain, especially in the chronic phase, but much less an ACL tear.
A little bit.
A little bit of pain moving up into the quad tendon, moving down into the tib tube. Oh yeah, there she is. Right there. Okay. And then kind of from the tib tube, finding that tibial plateau. Moving along the lateral joint line until you really feel that band. There it is. That's the ACL, that nice banded rope. And then just moving medially, finding that tibial plateau along the medial joint line. Tougher. And just poking around there. You can also do the lateral condyles, or the condyles of the femoral condyles. There's lateral, and there's medial. And then go ahead and lay on your back with your head facing that way. Actually, stay up for me one more time.
Sure.
Before I had her lay down, I would do a quick DMMT, so just for time's sake, I'm just going to check the affected side, but I would check the unaffected side just for a baseline. So go ahead and kick this leg out for me, and then bring it down a little bit. Don't let me move you. Say a 4 plus, and then pull your leg back. Other way. Don't let me pull you. Then a 4 minus that. Either of those ways hurt?
No.
Oh, no pain? Okay. Now go ahead and lay on your back. And then I would do just a quick active range of motion check. So go ahead and slide that heel towards your butt. And then realistically, I would use a better goni, but this is the one I can find. So find those bony landmarks. Just get along. Quick glance. And about 115. I'm going to go ahead and straighten that leg as much as you can for me. Drive it down. And just a quick glance. And we're looking at about maybe 2 degrees hyperextension. And then I can also do some quick P-ROM. Just get end feel pretty firm. And relax. I can just go into end range P-ROM for the knee. We're getting more so close to about 125. And then for P-ROM extension, about 4 degrees hyperextension. And then just a couple quick ACL tests we could do. Quick Lockman's test. So just bring it up to about 30 degrees of flexion, and then giving a quick pull, and relax. Just checking for any laxity, any excessive anterior translation of that tibia. And then another one I could do, it's not as good anymore compared to the Lockman test, but we could do the anterior drawer, where I just provide that anterior force, checking for that excessive anterior translation. And then as well, while I'm here, I could do a quick APPA mobilization. So just hand along the tibial plateau, and then just pushing in, checking for any mobility. So pretty normal that way. And then kind of the same position for the anterior drawer. Now I would expect this to be hypermobile just because the ACL in this case is torn. Now, a quick mold that I can do for the patient is a grade 4 posterior glide of the tibiofemoral joint. So, same position. I like to put both thumbs on the tibial plateau just to give it a better, better contact. Actually, I better go this way for the AP. And then just small oscillations up into, up to and through tissue resistance. Really working on improving mobility there. Make sure I got everything. Palpation area right there. And then just some surgical considerations with ACL tear. A couple options we have. We have some autologous grafts, so that could be, hamstring, maybe more so kind of up and coming as quad tendon for ACL. And then we do have allogeneic grafts, which is more so from a cadaver donor. And then usually the criteria for having ACL reconstruction, minimal to no effusion, full range of motion, good quad control. So it's essentially the big one with that, no extension lag with the straight leg raise. And that's kind of my assessment I would do for a chronic left ACL.